I'm delighted to be here tonight, and I stand between you and dessert, so I will try and be relatively rapid. I hope to talk to you a little bit about something near and dear to my heart, the Medicaid program. I was absolutely delighted in the first breakout session that I attended to find out two great things. One, a lot of you are already members of MHPA. If you work for a large insurer that provides Medicaid coverage, you actually are members of the Medicaid Health Plans of America. And it was great to see a lot of folks doing a lot of good work for members of the trade association. And then secondly, I was shocked by the number of discussions focused on Medicaid. So hopefully none of this, look, they're already chirping because they know that I'm boring. So that's a sign I should get off the stage. Thank you and good night. No. But I want to talk to you a little bit about why I believe Medicaid is going to fundamentally change healthcare in the United States in the next 5 years. I've chosen an exploding star as the motif. There's a good reason for that. When Medicaid started in 1965, many people don't know that it was attached to the Medicare program. When LBJ signed Title 19 into law, he never mentioned Medicaid. It was always an afterthought. Unfortunately, it is a really important program that should be front and center in the United States because it is the single most important program for the disadvantaged in America. And I'm going to give you some stats that I always find tremendously just mind-blowing, and then talk to you about why that's actually going to impact healthcare over the next 5 years. First, let me talk about the growth, because that is the focus on almost everything. Medicaid is approaching supernova status. In the last 2 years, 13 million new Medicaid beneficiaries have joined the ranks. That curve represents a tremendous growth if you think about who's covered in the United States. Two interesting facts. In Medicaid today, 1 in 5 Americans receives their insurance coverage. That is tremendous in and among itself. Secondly, the cost of that is skyrocketing. In 2009, the combined federal and state expenditure for Medicaid was $390 billion. This year, it's projected to be $546. That growth rate is not sustainable for two large reasons. Many of you know that Medicaid is a joint federal-state program. When it was designed in 1965, the thought was the states would put up 50%, the feds would put up 50%, and it was generally thought of as a widows and orphans program. Today, the population is far bigger than that, and the spread in cost is no longer 50-50. The feds pay about 57%, the state pays 43%. Unfortunately for the states, because they all have balanced budget amendments, every dollar they spend in Medicaid is a dollar they're not spending building a road, paying a teacher, building a prison, or the other things that states need to do. It is a readily apparent expense. In fact, Medicaid is the number 1 or number 2 spending in 40 of 50 states and up to either the first, second, or third in all 50. So I would suggest to you that this program has become very large and very important, if only for cost and population. But it's more than that. Medicaid today is undergoing rapid change that this country has never seen in a major healthcare program. My trade association, the Medicaid Health Plans of America, every year puts out a study about how many Medicaid beneficiaries are covered in fully capitated insured programs. Last year, we released a study that said 67%, 2/3, were in an insured capitated program. We have an annual meeting every year. It's in 2 weeks, but since I know most of you are already members, I'm going to give you a little headline that you'll hear in 2 weeks. It's now 71%. That growth rate is staggering. And it's staggering because if you look at, I missed this curve. Let me skip this for a second. Let me go to this, thank you. Most of the population is now moving into this capitated risk model. If you think about where people live, I want to apologize if I sound dismissive, to the states on the right, most of those states, nobody lives there. They're relatively low population states, except 3 states in the darker red, Connecticut, Alabama, and North Carolina. Those 3 states don't have anyone in fully capitated physical care right now. All of that is changing, and let me just talk to you about those 3 states because I think they're interesting. Many of you are aware that North Carolina this year, about 3 weeks ago, just passed legislation that is going to move the Medicaid population into a capitated risk model, either run by providers or run by managed care organizations. This is groundbreaking for North Carolina. It's 1.7 million Medicaid beneficiaries currently are essentially fee-for-service. I would suggest to you when I get to the back end of this presentation that the PLE model is probably not the best way to manage the population health of a Medicaid beneficiary live. The other 2 states, Alabama and Connecticut, are also interesting. Alabama's program, which is provider-led, begins January 1st. It is modeled on a similar program that was started in Louisiana. Louisiana had a mix of ACO and MCO models, and within 2 years converted all of it to MCO. Lastly, let me talk about Connecticut. This is my favorite. Connecticut decided 2 years ago that they no longer wish to participate in managed care for Medicaid in their state, and they moved to fee-for-service because they wanted, presumably, better care, better quality. Well, guess what? They missed their number by $160 million. Providers are no longer accepting new Medicaid beneficiaries, and there is no indication that the care is better or the cost is less. So I think you're going to see these 3 states move to a capitated risk model, which means that the 50 million of the 70-odd million that are currently in Medicaid is going to shift rapidly, and that percentage that I laid out earlier, the 71%, is going to grow very dramatically. In fact, I believe, and it is the position of MHPA, that within 5 years you'll see 80% of the Medicaid population in a capitated risk model. And I actually think that's a good thing, and I want to tell you why. One of the challenges with Medicaid, and the folks in this room that deal with enrollees every day know this to be true, that Medicaid beneficiaries by their nature are sicker because they are poor. There are socioeconomic difficulties that they face that no one in this room ever has to face. Because of that, they tend to have higher chronic diseases. They are most certainly more likely to have both behavioral and substance abuse issues. And the challenge for the Medicaid program is how to integrate that care from behavioral health, substance abuse, multiple chronic diseases to start going toward a health system that moves them to a position where they can either graduate out of Medicaid into a subsidized insurance pool or live their life the way that they should. And this is the challenge the plans that I represent face every day. So what does all this mean? I promised that I would be relatively quick. I said I'd be about 25 minutes, and I think I'm going to make this by going through these 3 quick points. Medicaid enrollees are going to vote. In the past, whether you were Republican or Democrat, you often heard a lot of politicians say entitlements need to be cut. Medicaid's growing too fast. I got to cut it. Well, guess what? Cutting it now is incredibly hard. It's hard because Medicaid has gotten to the point where 1 in 5 Americans get their insurance through Medicaid, and it is soon to be 1 in 4. More than 50% of America receives their health benefits from Medicaid, Medicare, VA, or TRICARE. The days of commercial insurance running the market are probably limited. And I would suggest to you that the changes in Medicaid means that Medicaid is no longer a widows and orphans program, but it is in fact a middle-class entitlement. And let me talk to you about 2 items that means that Medicaid is going to be potent at the polls. The first is the expansion population. Many of you know that 40 states chose to accept the ACA's expansion ability, where they could bring folks in under 138% of poverty, but above what they were previously had at the state level, and the federal government would pay 100% until next year. It ultimately goes down 2% next year, ultimately down to 90%. That's still significantly better than the match rate that I told you earlier, so many states made the decision to expand. Well, who is covered in that expansion? Most of the expansion population, as almost all of you are aware, were single working men. So you're starting to see the working poor getting access to the Medicaid program as they either move into a subsidized model or actually move into employer-sponsored care. And if you think about the 138% versus, say, 100% of poverty, An interesting fact is that is a minimum wage job for part of the year. It's very easy to drop right back into Medicaid for folks that didn't do expansion. The other thing that a lot of people don't understand about Medicaid is I actually came from the nursing home industry before I took this job. 57% of all the money spent in long-term institutional care is spent by Medicaid. If you think about how's that possible, individuals in nursing homes in long-term care facilities are generally paid by Medicaid, not Medicare. When you're sick, you get sniffed and you get 90 days. But when you are housed, you're paid by Medicaid. And if you think about the way many individuals move from when they go into institutional care, there is a whole cottage industry of estate lawyers that will figure out ways to move the estate to the children so that you become Medicaid eligible. It's now a middle-class entitlement. Interesting fact from Pew just did a research on 40 to 50-year-olds that they call the sandwich generation. Those are individuals that have small children and are also caring for an adult. Of that sandwich generation, more than a third currently have at least one parent in institutional care. When you tell those voters, hey, I'm going to cut Medicaid, the first thing they think of is how am I going to pay that bill that averages $84,000 a year in nursing homes for 1 year. So it's very big. The second item that I think is going to fundamentally change Medicaid as we know it is who bears the risk. As I mentioned to you, we now have over 70% of the Medicaid market in a risk-based entity that is not the state. When my plans begin to look at ACO models, they tell me over and over again that they're not competing with ACOs, they're actually partnering with them. Because the ACO model allows them to agglomerate risk, to work with the providers to take an upside-downside risk to see how best to provide care to those enrollees. And what that tells me is it's all going to be about the data. When a large insurer enters into a contract risk arrangement with a ACO or a PLE or some other chandeliered product for providers, the question is going to be whose yardstick? What data? How am I going to measure whether I'm meeting the contractual requirements of population health, and how are you going to provide me the data so that I can audit it? One of the challenges that we hear almost daily from the plans in negotiation with large institutional providers is whose data, how much of the data, how quickly do we get the data, and who actually gets to make that call on the contract. I think this is an evolving thing, and I honestly believe that because the Medicaid space is so relatively thin in terms of profit, generally for insurers, the profit in a Medicaid plan is somewhere between 2 and 3% if you believe HMA. That's significantly less than what you get in commercial or ERISA insured products. That risk is going to be the keystone for how the Medicaid plans actually manage into the future. And that's why when our plans talk about ACOs, there's no longer this theory that they're threatened or that it's a competition. It's actually some form of coordination and cooperation. And then lastly, the move to a holistic approach. In healthcare generally, we've always thought of healthcare as, are we giving you the right drug at the right time? Are you being readmitted for something that could have been fixed earlier? But the truth is that in this population, wraparound services become incredibly important. If you think about a Medicaid beneficiary, they can't just hop in their car to go to a doctor because many of the times they don't have a car. Many of the times they can't get to a doctor because they live in areas where there are no providers. So the providers that they get access to are not doctors, but nurses or LPNs or other healthcare experts that provide that kind of care. The plans have contractual obligations to the state in terms of how long it takes to get to either a primary care physician or a specialist. And the plans are constantly working on how can I outreach to these physicians, to these healthcare providers a little bit better to bring them into my network. And that wraparound service helps drive both value to the beneficiary and savings for the plan and ultimately the state. And I'd like to give you an interesting example. While I was talking to some of the folks around here earlier, we were talking about a company called Voxiva. Can I see a show of hands? Anybody knows who Voxiva is? Awesome. There actually are people that do. They make a software program called Baby, it's called Baby and Me, I think is what they call it when it's not white labeled by the plans. But it's designed so that plans can push information to pregnant mothers about how best to care for themselves before they give birth. When Paul Meyer, who started the program, his idea was all about Medicaid. And it was focused on Medicaid because if you think about it, Medicaid plans, the single most expensive set of people they have to manage are pregnant women. Because in Medicaid, unlike, I don't know how many of you all are parents, but I know that when my wife was pregnant, we knew like on the 4th week. She was already taking the vitamins and she was doing the exercises and no alcohol, and God forbid she never stops drinking coffee again. But I can tell you that the plans, when they see Medicaid beneficiaries who are pregnant, they don't see them on the 4th week. They don't see them on the 8th week. They don't see them on the 12th week. They're lucky if they see them on the 18th week. Well, 18 weeks in is an awful long time. So the plans are really looking at what are the ways that we can push this data to individuals who are pregnant or likely to get pregnant so that we can reduce our single biggest cost, which is NICU costs. Interesting fact, 50% of the births in the United States are paid for by Medicaid. 50%. 93% of that is in capitated risk. Because if you think about it, no state wants to give a pregnant woman a card and say, hey, good luck finding a doc, we're good here, right? They want you managed. They want to make sure you're getting your vitamins. They want to make sure that if you need something, you get it, because NICU is incredibly expensive, right? So the plans are really looking at how they can get to those individuals, and the interesting piece about Voxiva has been tremendously successful. One of my plans uses it in 5 different states. They've got some amazing data at the implications of pushing that information out to pregnant Medicaid beneficiaries. And now Voxiva is trying to get every OBGYN in the United States to provide that app as soon as you come in on your first visit. Doesn't matter what insurance company you have or if you have no insurance at all, stick this app on there. It's making the jump from Medicaid into the commercial market, and I think ultimately it'll be tremendously successful. So when you think about these 3 things, what does it all mean wrapped together? Well, from my perspective, I think it means 2 very large changes to the system. In my view, the first is the imperative of big data. My original slide deck, I had a piece from Lord of the Rings, and the piece was going to be one data to rule them all. And I couldn't quite fit it in, and we couldn't get the trademark anyway. But the piece to this, the reason this is important is if you think about Medicaid plans, and you think about the folks that I represent, 2 of my plans have over 5 million Medicaid beneficiaries. Most of my plans are in multi-states. The fact they have all of this claims data, all of this experience data, allows them to make decisions that states never could. And I think that data and that data analysis is going to start driving decisions which are ultimately going to provide better care to the beneficiary and ultimately will result in bending the cost curve. And I really do believe data is going to be the key. The question is going to be whose data, how much data, and who gets access to the data, and that's to be fought over for the next 5 years. The other thing is this, that over the next 5 years, the growth of Medicaid, regardless of who gets in the White House next year, is not going to slow down. If you think about it today, right now, with 72 million Medicaid beneficiaries, you still have states like Florida, Texas, and others that have not expanded. You literally have a pool of about 90 million Americans who could qualify for Medicaid, even if the states that have not expanded ultimately do expand. 90 million Americans. The sheer weight of those individuals, I believe, is going to have a major impact on how the health system deals with getting folks through the entire system and looking at them holistically. The concept now of them showing up in the emergency room, the plans struggle every day with how do we get individuals who we can't see to actually not go to the emergency room when they need care immediately. How can you disincentivize a program where in Medicaid you can't really charge the beneficiary? And that's a challenge that we're going to have to ultimately face with 90 million people that are eligible for this program. So I'll just end it there. Like I said, I know I'm between you and your dessert. I really do believe that most of the people in this room are going to provide those answers. I was incredibly impressed with the discussion today about how they can use data to drive the system. And so I'll end here with just a couple of questions. And thank you for your attention. I really appreciate it. Anybody? Any questions, or would you rather just get to the key lime pie? Yes, sir.
Quick question. What's your opinion of disrupt initiatives in the United States? And I'm particularly familiar with the New York initiative, which is
So the question was on disrupt. This is for those of you who don't know, and I'm sure almost all of you do, the federal government decided under the ACA that they'd get this giant pool of money and they would look at, were there new systems that could be created for financing or provider access that could fundamentally change the system. How many states is it 9 or 12 that have disrupt grant? But the money is tremendous. I mean, I think New York has drawn down like well over $2 billion, I think it's the last number that I saw. So I think there are two issues. When my trade organization goes in and talks to the folks at HHS, there is a lot of interest of getting the providers closer to the Medicaid beneficiary. And I think there's a lot of good reason to do that. And I'm in no way suggesting that they're wrong. But I would say this, that when I visit the plans, and I've been very lucky where the plans have been kind enough to kind of walk me through the system, it strikes me as challenging for plans that even have great access for their beneficiaries to actually know where those beneficiaries are. And it isn't clear to me that just providing more access will necessarily create better access. Now, I know some of the programs are ultimately going to work, some will fail, we'll see, they're all experimental. But there is one program in New York that I know two of our plans are working on where it is a combination of providers providing telehealth and teleaid. And so the concept is around both coaching on mobile devices and then telehealth to help drive some decisions around, I think the focus is diabetes, which is obviously a huge problem in Medicaid. I think it actually has a chance. We'll see if any of them get adopted. Yes, sir.
How do you feel some states, I'm from Maryland, they keep locking off body parts.
Yep.
The behavioral health and that substance
Yep.
abuse are a separate vendor.
Yep.
Good vendors, but we kind of believe that the body is connected.
Well,
How does your organization feel?
we absolutely agree. We 100% believe that for a Medicaid program to truly work, particularly given the behavioral health issues that Medicaid beneficiaries face, both substance abuse and SMI, that it makes no sense to us at all that you cut those two things apart. If you think about it, it's kind of in our view, it's kind of a archaic feature of Medicaid, right? Originally, when Medicaid came out, many of you may know that they carved out mental health asylums from coverage because the states were already providing that and the feds didn't want to pick up the cost of care. I think CMS, under the latest reg, moving forward very close to the line on what they can actually provide for states to be reimbursed for care for behavioral health break is a good thing. Ultimately, we'd really like to see all that stuff combined, and I think, and I'll use North Carolina that I alluded to earlier as a great opportunity to show how well that'll work. North Carolina has a program that they've been running for over 12 years that a private organization provides capitated risk for behavioral health only. Cardinal has 265,000 individuals in a capitated risk behavioral health program. Now that they're moving to physical health, it makes sense that Cardinal should see if they can pick that up as well. And it'll be interesting to see whether there's actually data that shows that behavioral health link actually saves money. One of the things you all may know is that in a recent survey looking at individuals going to primary care physicians that were paid for diagnosis of depression actually diagnosed a lot of Medicaid beneficiaries as depressed, and that was a comorbidity of their health issues. Anyone else? Yes, ma'am.
Crazy question.
Okay. Well, then, if it's too crazy, should I ask them to stop rolling the tape and I'll... Yes, ma'am.
Are there any health plans doing anything to get people off Medicaid?
So that is a great question and not crazy at all. MHPA.org, if you're interested, every year does a compendia of best practices. And last year, we had a number of plans submit ways that they're trying to reduce churn. And the reason I mention churn is, to me, this is an amazing statistic. The plans, four of my companies that are in the South got together as a cooperative and looked at data, and it was suggested to me that they have a churn rate of approaching, in a 12-month period, 80%. So the odds of someone being in a plan the full year is like 20%. The churn rate is tremendous. And one of the focus that this plan developed and is part of our compendia was trying to reduce the churn so that they churned from Medicaid into a subsidized program and trying to move them on the continuum. And if you think about the ACA, a lot of people forget that Medicaid was the key to getting folks to subsidized coverage. There's a reason that the ACA was designed to require all the states to do a Medicaid expansion, because it was a way to jump people into the subsidized pool. And once it became fragmented, you had states that didn't expand, so now you've got this giant hole. And so the states that did expand, these plans actually looked at, could you try and reduce churn by providing them the same network in a subsidized market versus a Medicaid market, knowing that these individuals are going to swing back and forth. And the data is pretty compelling. I think the one thing that was interesting to me about the data is the relative rate of reduction in churn through the plan was statistically meaningful, but it was only about 10%, I think. And that's available at mhpa.org on the Compendia of Best Practices. Anyone else? Anyone? Well, I'd like to thank you for having me, and I really do appreciate it. I look forward to the next 2 days, and enjoy your dessert.
Well, before I'll let you get your dessert, thank you again. That was fantastic.